Hi and welcome back to another video of Medic Notes. This video is on SIADH, which is the syndrome of inappropriate ADH secretion. SIADH is defined as less than maximally dilute urine in the presence of serum hypoosmolality in patients with normal adrenal, thyroid, renal, hepatic, and cardiac function who do not have hypotension, volume depletion, or other physiologic causes of vasopressin secretion. SIADH is associated with myriad disorders. Hyponatremia is the result, and symptoms are those of hyponatremia. Diagnosis is by measurement of serum and urine osmolality and electrolytes. Treatment is with water restriction, sometimes with oral or intravenous sodium chloride, and rarely with vasopressin receptor antagonist medications such as conivaptan or tolvaptan. For the pathophysiology, ADH, also called vasopressin, is a hormone produced by the posterior pituitary to help control fluid homeostasis. The hormone increases water reabsorption in the distal nephron, producing a concentrated urine and diluted plasma. Vasopressin release is stimulated by any of the following: increased plasma osmolality, decreased blood volume, decreased blood pressure, stress, or certain medications. Low plasma osmolality inhibits vasopressin secretion, allowing the kidneys to produce dilute urine. Vasopressin release is inappropriate in the presence of normal or low plasma osmolality, and normal or high blood volume and blood pressure. In such cases, the water inappropriately retained by the kidneys ultimately causes euvolemic or dilutional hyponatremia, in which total body sodium and thus extracellular fluid volume are normal or near normal. However, total body water is increased. These are the possible causes of SIADH: cancer and neurologic disorders, pulmonary disorders and others. Many medications have also been linked to SIADH, such as analgesics, antidepressants, anti-seizure drugs, antipsychotic drugs, and cytotoxic drugs. Symptoms of SIADH are those of hyponatremia, which mainly involve central nervous system dysfunction and generally occur when the effective plasma osmolality falls to less than 240. Symptoms can be subtle and consist mainly of changes in mental status, including altered personality, lethargy, and confusion. As the serum sodium falls to less than 115, stupor, neuromuscular hyperexcitability, hyperreflexia, seizures, coma, and death can result. SIADH is suspected in patients who have hyponatremia and are euvolemic. Inappropriately high urine osmolality compared to serum osmolality in a euvolemic patient. And normal adrenal, thyroid, renal, cardiac, and hepatic function. How do we differentiate diabetes insipidus versus SIADH? The urine-specific gravity and osmolality will be low in D, but high in SIADH. Whereas serum sodium and osmolality are high in D, but low in SIADH. For treatment, treat the cause: fluid restriction, vasopressin receptor antagonist, such as conivaptan or tolvaptan, and hypertonic saline. Hypertonic saline infusion should be reserved for patients with severe, symptomatic hyponatremia, and should be used cautiously because too rapid correction risks complications, such as the osmotic demyelination syndrome. Typically, correction should aim to raise the serum sodium by no more than 8 mmol per liter over the first 24 hours. Key points: patients with SIADH are euvolemic and have low serum osmolality but inappropriately high urine osmolality. Despite the name, not all patients with SIADH have excessive vasopressin. Causes include central nervous system disorders, lung disorders particularly infections, certain cancers particularly lung cancer, and certain drugs. Water restriction and treatment of cause may be adequate. Some patients will also require a vasopressin receptor antagonist or hypertonic saline. That's all for this video. Thank you.